this opportunity. Thank you, respected Sharda Jain ma'am, for this kind introduction of the subject and opportunity extended to me. So I'll be sharing my presentation. Actually, I just want to admit that these have been taken from the latest ASHRAE guidelines 2023. So let me share my screen. So what is new in PCOS? The introduction has been given by Madam. What is PCOS and why it is important to read about it. So the latest guidelines have been introduced in 2023 and they are evidence-based guidelines for the assessment as well as management of polycystic ovarian syndrome 2023. So it is a mixture of all from guidelines from MANASH, ASRM, Endocrine Society, ASHRAE, European Society, etc. So the categories are based either on evidence-based, which are highlighted in purplish color. The pink color is consensus recommendation. Because much evidence is not there, they have made a consensus and it is highlighted in pink. And the amber color or the orange color are the good practice points given, although evidence was not sought for them. And grading, we all know that conditional recommendation which is given against any option is given 1 grade. Grade 2 is conditional recommendation for either the option or the comparative, alternative treatment available. So a grade 4 means strong recommendation for that particular option. And quality of evidence is given in plus mark, which is highlighted by a circle, and it depends on the grade also. So they are at every recommendation, they have given grading as well as quality of evidence category. Now, the screening and diagnostic and risk assessment life stages is the first part of the recommendation which was given by ASHRAE. And the general principles are all diagnostic assessments are recommended for use in accordance with the diagnostic algorithms. At the end of the presentation, I have algorithms also. If the time permits, I will be sharing for you. They have given guidelines about irregular cycles, how to define irregular cycles and ovulatory dysfunction. We all are aware of that normally in the first year post-menarche, it may be a part of the pubertal transition. And if the girl is more than 1 year or less than 3 years post-menarche, the menstrual cycles should be between 21 to 45 days. They are normal. If they are less than 21 or more than 45 days, then you call them irregular menstrual cycles. But if the adolescent is now 3 years post-menarche, then for labeling irregular cycles, the cycle should be either less than 21 or more than 35 days. To make it easier to understand, if the girl is having less than 8 cycles per cycle, you may consider her to be having irregular menstrual cycles. But if the girl is now more than 1 year post-menarche and she is not getting periods for 90 days, you will label her as having irregular cycles. And if the girl is now post 15 years or post-thelarche more than 3 years, that means breast development has started 3 years back and still the girl has not menstruated, then you can diagnose or label her to be having irregular cycles and ovulatory dysfunction for that matter. And when irregular menstrual cycles are present, a diagnosis of PCOS should be considered and assessed according to these PCOS guidelines. And we must understand, we must give due consideration to the fact that menarche may be different. Age of menarche may be different in various populations, and the value and optimal timing of assessment and diagnosis of PCOS should be discussed with the patient and their parents or guardians, considering the diagnostic challenge at this life stage and psychological and cultural factors which may be issued for them. If you cannot label her to be having frank PCOS, because she may not be having all the diagnostic criteria which have been met, she should be labeled to be having an increased risk of developing PCOS later on in life. And because she may be put on COCP for that commencement to avoid development of PCOS later on, especially with persisting features, and if there is a significant weight gain in adolescence. One thing I wanted to highlight is that ovulatory dysfunction can still occur with even regular cycles. And if an ovulation needs to be confirmed, you can either do serum progesterone. Now, they gave certain recommendation, and you all will very well appreciate they are all in purple color. They are the evidence-based recommendation. So they gave recommendation both about biochemical hyperandrogenism and clinical hyperandrogenism. So initially we are going to discuss biochemical hyperandrogenism. That is, healthcare professionals should use total and free testosterone to assess biochemical hyperandrogenism. They have given this guideline. And if testosterone or free testosterone is not elevated, in these conditions, you should consider doing androstenedione and dehydroepiandrosterone. And one thing is that with the greater age, poor specificity is there. And because as the age advances, DHEAS is likely to decrease. So you have to give this consideration. Lab should be validated, and you should use accurate tandem mass spectrometry. It may be liquid chromatography, LCMS as we call, or simple mass spectrometry. I will highlight this point further also. These are the lab standardization which are given for total testosterone if needed, and also for androstenedione and DHEA also. And what you can do is you can just calculate free testosterone by calculation, equilibrium analysis, or this is the new method, ammonium sulfate precipitation. So this is more for relevant for the lab people. And these are to be preferred over direct immunoassays. Initially, we were doing either radiometric or ELISA-based tests, but now they said that it should be accurate tandem mass spectrometry. Now, for the detection of hyperandrogenism, especially in PCOS, the assessment of biochemical hyperandrogenism is of great value, especially in patients who do not, have clinical signs or symptoms of hyperandrogenism. That is, they do not have explicit hirsutism. In these patients, it becomes very, very relevant. And they say that it is difficult to assess for biochemical hyperandrogenism in women on COC. Like if you have started a girl already on COC, if you want to do her biochemical analysis for androgen assay, you have to stop OCPs for at least 3 months. Only then you will have reliable value which can be considered for diagnosis. Repeat androgen measures in adults have limited role. So I just want to highlight that there is no point in getting androgen again and again. Now, we must remember that androgen levels reach adult range between 12 to 15 years of age. And if the androgen levels are markedly above lab reference range, causes of hyperandrogenemia, as we have already always taught, that you have to rule out other clinical problems like ovarian and adrenal neoplastic growth, congenital adrenal hyperplasia, Cushing syndrome. Especially in postmenopausal, you have to rule out ovarian hypertrichosis. There may be iatrogenic causes or syndromes of severe insulin resistance can sometimes present with high androgen levels. Now, all the labs should have their population-based reference ranges, and they should consider what is important for clinician is that they should have reference ranges in their particular population or a larger population values, which is determined by cluster analysis. And they have to apply most accurate method, as I've already told, and chromatography, immunoassays, extraction immunoassays, or alternative to mass spectrometry, which is ideal. And what they are planning is that future improvements may arise from measuring 11 oxygenated androgens and by determining their cutoff values for diagnosis of PCOS. Now we have talked about biochemical hyperandrogenism. Now comes the turn of clinical hyperandrogenism, that is that presence of hirsutism alone, it should be considered predictive of biochemical hyperandrogenism and PCOS, meaning thereby if the patient is exhibiting hyperandrogenism in form of hirsutism, patient should be given a consideration for ruling out PCOS, and especially in adults. Healthcare professionals could recognize that female pattern hair loss, as I have shown in the diagram above, or acne and acne in isolation are relatively weak predictors of biochemical hyperandrogenism. Because female pattern hair loss cannot be directly related to biochemical hyperandrogenism. It is more a component of other causes. Like you see this Christmas tree loss of pattern, this is female pattern hair loss. So it is a weak predictor of biochemical hyperandrogenism. A comprehensive history and physical examination you should do to completely look for symptoms and signs of clinical hyperandrogenism. What you will do is you will see for acne, female pattern hair loss, and hirsutism in adults. And as far as adolescents are concerned, it will present with severe acne and hirsutism. So we must also consider that there may be negative psychosocial impact of this clinical hyperandrogenism, and we should consider reporting of unwanted excess hair loss or female pattern hair loss as being important regardless of its clinical severity. So we are doing hirsutism by using this modified Ferriman-Galway score. These, these points are highlighted: upper lip, then chin, upper part of chest, upper part of abdomen, lower part of abdomen, then upper arms, thighs, medial aspect, especially upper back and lower back. You do assessment, and if your score is between 4 to 6, you can label her as hirsutism. And one must remember that there may be certain ethnic groups which have higher hair growth, and you should rule out that patient has had self-treatment. When you are doing initial assessment, she might have got threading or waxing done. So you have to acknowledge these facts also. Now, these are certain practice points which were given, that you should be aware of the standardized visual scales. And you can use Ludwig or Olsen visual scales. They are readily available. You can place them in your clinics for assessing the severity of female pattern hair loss. And unfortunately, regarding acne, there is no universally accepted visual instrument. What you can do is you can take a photograph, and while patient is on treatment, you can then compare it later on. Then one must appreciate the self-assessment by the patient also. She will also tell you whether she is improving or not. What they wanted to tell was that these terminal hair, which can gain length up to 5 millimeter, if they are not treated, then they may become as long as more than 5 millimeter. They may vary in shape and texture also. Sometimes they may be very coarse and pigmented also. One must rule out that if there is a sudden severe onset and worsening hyperandrogenism, we have to rule out androgen secreting tumors, which has been highlighted time and again in the recommendations. And we must monitor clinical signs of hyperandrogenism, including hirsutism, acne, and female pattern hair loss. And you have to see whether there is improvement by the treatment. Now, they have given guidelines about ultrasound and polycystic ovarian morphology also. One must remember FNPO. FNPO is follicle number per ovary, should be considered the most effective ultrasound marker to detect polycystic ovarian morphology, especially in adults. Follicle number per cross section is also important, as well as ovarian volume has to be taken into consideration while we are helping it as a tool to confirm or lead to diagnosis of polycystic ovarian syndrome. As far as the PCOM criteria should be based on follicle excess and or ovarian enlargement. Both are very, very important, both number as well as ovarian enlargement. Follicle number per ovary more than 20, even in one ovary, should be considered the threshold for PCOM in adults. Ovarian volume of more than 10 ml or follicle number per section of more than 10. Like you are doing TVS, and in various section, if you find that per section, if the follicle number is more than 10, then because we have now very good image quality tools are available, so you, for accurate assessment, you can give consideration to these 2 points. As far as adolescents are concerned, it is not recommended. They have clearly mentioned in the practice point that there are no definitive criteria to define polycystic ovary morphology on ultrasound in adolescents. So it is not recommended in adolescents. When ultrasound is indicated, if acceptable to the individual, the transvaginal approach is the most accurate for the diagnosis of PCOM. But unfortunately, in young girls, we will not be able to do it. If the patient allows, you can do either transperineal or you have to resort to transabdominal also. But as far as transabdominal, ultrasound should primarily report ovarian volume with a threshold of more than 10 ml or follicle number per section more than 10 in either ovary in adults, given the difficulty of assessing follicle counts throughout the entire ovary. Because in abdominal, sometimes it really becomes difficult to count the number of follicles per section, as it can be easily done in the transvaginal one. Now, if the patient is already giving you history of irregular menstrual cycle and you have clinical or biochemical hyperandrogenism, and ovarian ultrasound is not necessary for PCOS diagnosis. And they say that threshold for PCOM, as you know, the clarity of ultrasound image improves, you have better ultrasound tools, so you might be having to revise the PCOM morphology regularly.
Dr. Anita, please mute yourself. Thank you.
Now, what they say is that the clinician should be, having standardized protocol how to report PCOM, that is polycystic ovarian morphology, on ultrasound. There are good practice points given. Please pay attention to this, that you should mention the LMP or particular stage of cycle at which you have got the ultrasound done, what was the transducer bandwidth frequency used, what was the approach, was it transabdominal or transvaginal, or what were the total number of follicles per ovary, was the ovary measured in 3 dimensions for calculation of volume, and other features. Please try to imbibe this fact that other ovarian features or pathology, including ovarian cyst, corpus luteum, or any dominant follicle which is more than 10 ml, it should not be included in ovarian volume calculation. I mean to say that if you have any ovarian cyst, you cannot take into consideration, you have to subtract it for calculation of ovarian volume. And if you find that the one ovary is having dominant follicle, it is better you resort to the contralateral ovary for diagnosis of PCM, because it will give you better picture. So they say that reliance on the contralateral ovary, follicle number per ovary for diagnosis of PCM becomes more relevant. And along with that, please have a look on uterine features and other pathology, including endometrial thickness and pattern, because it may be important because of associated hyperestrogenic states. Now, clear-cut evidence-based recommendations were given for importance of anti-Mullerian hormone as far as diagnosis of PCOS was concerned. They said that as far as adults are concerned, serum AMH can be used for defining PCOM. Please mind, could be used. They use the word could be used. And +3 recommendations are given depending on the reliability of this. But they say that it should be used in accordance with the diagnostic algorithm, noting that in patients with irregular menstrual cycles and hyperandrogenism, AMH level is not necessarily for PCOS diagnosis. They recommended that serum AMH should not be used as a single standalone test for the diagnosis of PCOS. It can help you in corroboration, but not as such for the diagnosis. As far as adolescents were concerned, they were very clear that evidence does not support that serum AMH can be used for diagnosis in adolescents. Good practice points were given that either serum AMH or ultrasound may be used to define PCOM. However, both the tests should not be performed to limit overdiagnosis. Lab and healthcare professionals need to be aware of the facts that influence AMH in the general population, because these are the factors which may affect the AMH value themselves, like age. Serum AMH generally peaks between the age of 20 to 25 years in the general population. BMI can affect the AMH level. They have seen that the girls or women having higher BMI will have less serum AMH. As far as use of hormonal contraception and ovarian surgery is concerned, this may be causing suppression of AMH levels. Suppose if the girl is on COC, combined oral contraceptive pills, her AMH is likely to be low. Or if the woman has had any ovarian surgery, the AMH might be fallaciously low. And it will also depend on the phase of menstrual cycle, they say. Lab involved in AMH measurement in females, they also should have specific cutoffs depending upon their population. Now, ethnic variation was very important. They have given evidence-based recommendation that healthcare professionals should be aware that there is a high prevalence of PCOS in all ethnicities and across world religions. It is ranging between 10 to 13% if we are using Rotterdam criteria. And there should be awareness that it can go across world regions and ethnicity, but we being Southeast Asians and Eastern Mediterranean region population is more likely to have PCOS. And the presentation may be also different in various ethnic groups. This was the importance given and attributed to ethnic variation. Now, menopause as life stage. There were, this recommendation based on the consent of various experts that a diagnosis of PCOS should be considered as enduring and lifelong. We know this fact. And healthcare professionals should consider that both clinical and biochemical hyperandrogenism persists in the post-menopause for women with PCOS. This is the disease or the syndrome which will affect the women across all ages. PCOS diagnosis could be considered post-menopause also if there has been a past diagnosis or there is a long-term history that patient had oligoamenorrhea with hyperandrogenism, or there was a polycystic ovarian morphology in the past during early reproductive years. Now, if we have already discussed that a new onset, severe or worsening hyperandrogenism, even in menopausal women, should raise an alarm in your brain that it may be a androgen secreting tumor. Or ovarian hypertrichosis as such in postmenopausal women may be a cause of this. There were clear evidence recommendation about cardiovascular disease risk. This is very important. because women with PCOS should be considered at increased risk of cardiovascular disease and potentiality of cardiovascular mortality. And all women with PCOS should be assessed for these risk factors as well as other risk factors which may be contributory. All women with PCOS, please get their age, regardless of their age or BMI. They should have ideally lipid profile. They were, this is consensus-based statement. Both cholesterol, LDL, HDL, all these in triglyceride level, they should be determined at the diagnosis stage itself. And frequency of further follow-up will depend on what additional risk factors the girl or the woman has. All women with PCOS should have BP measurement annually, especially when planning pregnancy or seeking fertility treatment, because there is a high risk of hypertensive disorder or pregnancy in these women. And it should be there that all funding, all public health system, they should be aware that PCOS is definitely a risk factor for increased cardiometabolic diseases. And it should be included, that is, PCOS should be included as a public health problem while determining cardiovascular risk factors. And you should prioritize preventive strategies to reduce cardiovascular risk in all women diagnosed with PCOS. Then there is chance of impaired glucose tolerance. We all know this fact is well known. There is increased risk to develop type 2 diabetes. It may be regardless of their age or BMI. So I will not dwell upon this because there is nothing new about it, and this has been well documented already. And even in adolescents, you should know the glycemic status right at the time of diagnosis. And there may be guidelines that depending on other risk factors, you might need to reassess it every 1 to 3 years. 1 to 3 years, sorry. Healthcare professional women with PCOS and other stakeholders, they have to make preventive strategies to develop type 2 diabetes risk later on in these women. So these are the public health issues which were given, that they should all be taught about this, and their even first degree relatives, they should ideally be aware of increased risk of diabetes in them also. So not only sisters, mothers, but brothers and father also need to be careful about this. And screening should be considered in individual with diabetes and her relatives also. What testing is done? 75 gram OGTT was given as per evidence-based assessment, and you might consider HbA1c, but the accuracy was not clearly defined. And they say that OGTT should be considered in all women with PCOS, even without pre-existing diabetes, especially when she is planning pregnancy or seeking fertility treatment. And insulin resistance is a pathological factor in PCOS. However, practice point was that insulin assays are of limited clinical values and not recommended. OSA, very important. There was evidence-based recommendation that all women with PCOS have to be screened for this obstructive sleep apnea. How will you know? That she might give you a history of snoring, waking unrefreshed from sleep, daytime sleepiness, and always feeling fatigue. So these are the screening. There are various screening tools, Berlin score, etc. You can use them. If you wish, I can share them later on with you. There is a clear-cut questionnaire as far as Berlin validation is concerned, and it can guide you whether this girl or woman has obstructive sleep apnea. So the carry-home message is that you must screen these women for obstructive sleep apnea. Endometrial hyperplasia and cancer, this is a time-tested recommendation that they should be, all healthcare should be aware that premenopausal women with PCOS have markedly high risk of developing endometrial hyperplasia as well as endometrial cancer. And but however, they say that although there is an increased chance, but routine screening was not recommended still. And long-standing untreated amenorrhea, higher weight, type 2 diabetes, persistent hyperplastic endometrium, they are the additional risk factors for developing endometrial hyperplasia along with having PCOS. So you have to take the preventive strategies like weight management, cycle regulation. You should not allow them to have prolonged amenorrhea, and they should be given progestogen therapy if they have amenorrhea like this. Risk in relatives was very importantly highlighted, especially regarding fathers and brothers, as I have already told you that PCOS women, their father or brothers are more likely to have metabolic syndrome and associated problems like type 2 diabetes and hypertension. However, surprisingly, the risk factors for female first degree relatives of women with PCOS still remains inconclusive. This was the first part. Then the second part was screening and management for psychological features. So it defined that psychosocial problems are very important, which affects the quality of life in these PCOS women. So clear guidelines were given that they should be screened for depression as well as anxiety, and they were evidence-based. This thing that there was higher incidence of both depression and anxiety in them. And severity of symptoms will guide you whether you should manage her by your own self, or you might need to refer this patient to a psychologist or psychotherapist. Similarly, you have to screen them for psychosexual function also, because they say that because of higher weight, hirsutism, mood disorders, they might be suffering from psychosexual problem. So please take their permission. If they are comfortable, discuss with them, take their consent. If they are open to discuss about their psychosexual problem, please discuss these problems with them and screen them for them. Body image issue is already well known, and you have to see whether these body image issues are leading to problems in her quality of life. Now, this is one very important thing, that PCOS women have to be screened for eating disorders and disordered eating. Eating disorders are very well established, like bulimia. This is an eating disorder, while disordered eating is the girl is not eating good dietary food, as madam has highlighted time and again, that these women should have balanced diet. But now women are going for ready-made foods, outside eating, and all this comes under disordered eating. So there is a slight difference. Eating disorders are the severe kind of disordered eating. So we must read about them, and we must screen these women for them. There is evidence-based recommendation regarding the same. As far as information resources, model of care, and cultural considerations was concerned, this was for public health policy makers, and they have developed models of care which were suggested. And the support should be there for PCOS, and all they said that all the undergraduate and PG teaching should involve to fill the gap of PCOS knowledge in the healthcare providers. So this was the evidence-based guidelines which I have highlighted to you. Psychological therapy, especially for depression, anxiety, clear guidelines are there. There are consent statements. So they should be screened for disordered eating, body image distress, low self-esteem, which is so common in them. Then feminine identity, psychosexual function, all these might need cognitive behavioral therapy, may need antidepressant and anxiolytic treatment also. Then the recommendations were made for lifestyle management. There was evidence-based that exercise alone or multi-component diet combined with exercise or behavioral strategies should be recommended. And the behavior should be, sometimes you have to guide them about the weight management. It may not be simply how to lose weight. You may ask them that they should maintain a heavy weight, normal, healthy weight, I mean. And they should avoid weight gain. Or if they can do it, it is modest weight loss which is advisable to them. Because sometimes patient may not be able to achieve the loss of weight, so she might get troubled by this, this fact only, that she is not able to gain or prevent further weight gain. So the focus is on prevention of further weight gain. This is as per the practicing points. And if the goal is to achieve weight loss, a tailored energy deficiency should be prescribed for women. And the value of improvement in central adiposity. This is very important because central adiposity is what is important for cardiometabolic health. So you have to just guide them. And ongoing support should be given. And you have to take out the weight stigma. When you are treating this patient, there were practicing points that you should try to counsel them, and they should be, the clinician should be aware of the weight stigma that the patient may have, and you have to discuss as and when you get the opportunity. There are certain behavioral strategies which may be required. I will not discuss in detail because of lack of time. Dietary interventions were there. And they said that no particular fat diet should be given. Whatever suits as per her food preference and ethnicity, they should be counseled about good dietary intake. Exercise is another part which is very, very important. Diet as well as exercise, both are relevant, and both along with each other can lead to consistent results. 60 minutes for adolescents, they say, and we have already known that at least they can be in spurts also, 10 minutes duration, 3 times a day. You can do that way also. Then you should teach them about what things lead to weight gain. They have to be discussed that further weight gain is not allowable. So you have to give them health, good lifestyle strategies along with that. Then there were non-fertility features issues, how to treat them. Then they were giving practice points about what treatment can be given. Pharmacological treatment, they were mainly concerned about giving COCPs. That was the highlight. And they said that low dose estrogen containing COCs were preferred. And second line will be ethinyl estradiol combination with cyproterone acetate. Please mind that cyproterone acetate combining COCs are the second line. First line are usually available in public health, like Mala and Malati. They said that, and it is evidence-based also, because they were saying that it should be cyproterone acetate containing preparation should be second line because of associated risk factors of this thing, thromboembolism. And even they have used progesterone-only contraceptive pills for endometrial protection in PCOS girls. Metformin, they have highly recommended. Metformin along with in itself, or metformin along with COCs. They were evidence-based recommendation that the results were better. Anti-obesity pharmacological agents, yes, they should be considered if your patient is not able to lose weight. You have tried all the anti-obesity medications like liraglutide, semaglutide, then even they recommend that they can undergo surgery for the same. Inositol, yes, but as such, they have, they said that it has limited harm, potential for improvement in metabolic measures, yet with limited clinical benefits. So it was not much recommended. Mechanical laser and light therapy for cosmetic purposes, they have said, yes, it can be a good practice point. Metabolic surgery, as I've already highlighted, if your patient is not able to lose weight, you can advise her bariatric or metabolic surgery. For better pregnancy outcomes, preconception counseling is important, and you should counsel these girls that there are higher chances of weight gain during pregnancy, there are high chances of miscarriage, gestational diabetes, etc. ART, yes, it is advisable, and please tell them that ART will not have poor outcome in PCOS. they clearly said, which was evidence-based, that assisted reproductive technology in women with PCOS should be considered as not conferring additional risk of miscarriage, preterm birth, impaired fetal growth, etc. It will be like other. Metformin in pregnancy, yes, they say that it has been shown to prevent gestational diabetes, late miscarriages, hypertension in pregnancy, preeclampsia, macrosomia, etc. So it should be recommended. And still they say that should be counseled that consequences of metformin exposure on long-term offspring health remains still unclear. And there were some studies which suggested that there may be increased childhood weight gain, but causality was not certain. Then treatment of infertility has already been, much discussed. Not very strong recommendation, but good practice points were given. And they should be offered fertility management algorithms. And PCOS can be assured that pregnancy can be either achieved naturally also or with assistance. Use of vitamins, ovulation induction therapy, there is nothing new about it, so I will not discuss. One consistent statement I would like to discuss is consistent with routine preconception care in women with PCOS, planning pregnancy, weight, blood pressure, smoking, alcohol, diet, nutritional status, etc. They have to be there. Exercise, sleep, adequate sleep counseling, mental, emotional, and sexual health issues need to be considered for improving the pregnancy outcomes in these women. And there was evidence-based recommendation, that is, women with PCOS should be counseled on the adverse impact of excessive weight on clinical pregnancy, miscarriage, and live births. Tubal patency test, yes, they say, as per like others also, letrozole was, of course, the first line of choice for ovulation induction. They have clearly highlighted. Clomiphene citrate may be used with metformin. Metformin had a better ovulation induction region even if it was used alone versus placebo. And clomiphene citrate versus metformin, it was said that clomiphene could be used in preference to metformin in women with PCOS with anovulatory infertility and no other infertility factors. But you have to tell that multiple pregnancy will be increased with clomiphene citrate in these women. So ideally, it should be have a good monitoring. And it was seen that clomiphene citrate with metformin had better response. Gonadotrophins can be used. There is evidence-based recommendation, but you should tell the patient about the pros and cons of this therapy. They have said that a low-dose step-up gonadotrophin protocol should always be used to optimize the chance of volume follicular development and prevent OHSS. Laparoscopic ovarian surgery can be as a second-line treatment for those women who cannot come for follow-up regularly for gonadotrophin induction or for routine ultrasound follow-up. So you can offer them laparoscopic ovarian surgery also. IVF and in vitro maturation they have discussed, although they say that in the absence of absolute indication for IVF or ICSI, IVF should be offered in women with PCOS and anovulatory infertility if first or second line ovulation induction have failed. One more important thing is that women with PCOS undergoing IVF ICSI treatment should be counseled prior to starting treatment about the increased risk of OHSS. And you have to develop strategies to prevent this. Then there are various protocols they have discussed. They are all in the practice points, what trigger to be given. They have also given consensus statement regarding that. Choice of various treatment modalities has been highlighted. Adjunct metformin was advised to be used when you are giving these treatments also. IVM, the chance of IVM also they have discussed that it is evidence-based that use of IVM and ICSI could be considered in women with PCOS as an alternative to stimulated IVF or ICSI cycle. use of inositol in any form alone or in combination with other therapy could be considered only as experimental therapy in patients with PCOS and infertility. Then these were the various guideline methods they have given in detail. If you want, you can go through them. They have summarized it in the end, and algorithms were given. I don't have much time to discuss, but they have given clean all of whatever I have discussed in the slides. They are given in algorithms also. How to screen, diagnostic assessment, risk assessment at various life stages. It is given how to screen for clinical hyperandrogenism, ultrasound, role of anti-Mullerian hormone, etc. All this is given in the this thing also, algorithm also. All the algorithms are there at the end of the. You can use them as ready reckoners if you have read the this thing guidelines well. All these are available on the net also. So thank you so much. Thank you for giving me a patient hearing.